Hi, everyone. Good morning. Hopefully you had a nice break. Welcome to those of you who are viewing from your offices or from home. Just a couple of housekeeping things before we get started. When you ask a question, when we get to the point of Q&A, if you can come up to the microphones, the reason for that is, although you may speak loudly and we can hear you here, the people that are watching from their offices or on the live streaming really can't hear the question. So if you can, go up to the microphones, that would be great. For those of you that are in the room, your clickers, there seems like there's some confusion. So when we get to polling questions, discuss at your table. One person pick up the clickers or the polling devices. And all you need to do is hit, I think almost all of our questions are A, B, C, and D. So just choose either A, B, C, or D as far as the answer. And you don't need to hit send or anything. If you hit A and you're like, oh, shoot, I meant to hit B, then that's okay. Go and click B. It will change your answer. So that's it from the clicking device. As Mark said, we are going to use the folder number 4. I just want to review a couple of things that are in that folder. If you can have kind of readily available, and for those of you in the room, some of these things are in your folder. We're going to be doing an activity called the scavenger hunt. So there's a scavenger hunt handout. And then we will be using a pressure ulcer scenario coding sheet. So if you can have those readily available to you. Just a reminder that as we go through this, what you have posted will not have the answers. When you pull this down from the web, will not have all the answers in it, because then that's giving you the answers to the activity. But once we finish all of this training, the materials with the answers will be posted, and the idea behind that is then you can use that when you within your organizations for staff training. So today we're going to talk about the percent of residents or patients with pressure ulcers that are new or worsening, and the associated OASIS C2 items. And so, of course, we always start off with some objectives. We're going to start and look at the numerator, the denominator, what are some of the denominator exclusions, what are the measurement time frame and windows, some of the QM calculation algorithms, the risk adjustments, and then we actually will go through some of the items and we'll do some practice scenarios around coding or scoring those particular items. We hope that by the time that we complete these sessions, so I have this session, then we'll take a break for lunch, and then I'll follow up with the conclusion of these materials, that you'll be able to describe the intent of 1311 and 1313, and interpret the response options for 1311 and 1313, and then ultimately apply the instructions in order to accurately respond to the practice scenarios, and in fact, just use it in your practice. So I wanted to just start off talking about this term code. You'll hear me use the term code or coding the OASIS. And we wanted to make sure that everyone, so we had kind of this shared mental model, everyone understood what we're talking about. That when I'm talking about code or a coder, I'm not talking about a coder in your office that's maybe doing ICD-10 coding. This is about actually completing the assessment, coding the items, all right? So I just want to make sure that there's no confusion about terminology. So throughout my session, when I talk about coding the item, I'm not talking about a coder, I'm not talking about the ICD-10 coding, I'm talking about coding the correct response or accurately indicating the correct response on the item set. All right, so the percent of residents or patients with pressure ulcers that are new or worsening, we're going to be talking about this QM. What we're looking about here, it's adopted as a cross-setting measure to meet the requirements of the IMPACT Act. And so you've already started to hear this. You heard this from Stace Mandel, and you've heard earlier about this. And the idea here is you need to understand is what we're trying to do is across all the post-acute settings, so nursing homes, home health with the OASIS, inpatient rehab facilities, and long-term care hospitals, what we're trying to do is have these measures look the same, be coded the same, so now we can start to understand the quality of the care in each one of the settings, and then measuring that quality across all of the settings. And so with this particular measure, it's intended to encourage post-acute care providers to prevent pressure ulcers, although I think we're all trying to prevent pressure ulcers or worsening of them, and to closely monitor and appropriately treat existing pressure ulcers. But it gives us a sense, and we'll be able to measure as you look at it, apples to apples versus apples to oranges. So they were similar if you took the original kind of some of the definitions from the MDS as compared to the OASIS. They were similar but not exactly the same. And then some of these other settings really weren't looking at this at all or having to report it. So now all of a sudden we're trying to align all of these measures and have them be the same. So that's the reason, depending on the setting that you're working in, it may be a totally new item for you, or it's a tweak or an adjustment to a particular item. So it gives you the idea behind that. So the quality measure description, it reports the percent of patients with a stage 2 to 4 pressure ulcer present at discharge that are new or worsened since the beginning of the quality episode. And we talked about defining the quality episode as the pairing of the start or resumption of care, so the SOC or the ROC assessment, with the end of care assessment. And the measure is calculated using data from, of course, the OASIS. So what I want to do is we're going to start off. You've had a lot of activity this morning. We had a good break, but I want to spend about 10 minutes, and we're going to do an activity that we've used in some of our other trainings, and we call this the scavenger hunt. So for those of you who are watching this live stream, if you can pull out your scavenger hunt slide deck, and it looks something like this. I don't know if hopefully you can see this at home. For those of you here, you have a nice color copy of it in your folders. And what you'll notice is there's 2 slides per page, and you'll go through and there's some blanks in there. There are actually 9 blanks that you're going to fill in. And how are you going to get this information? Well, on your tables are this thing called the Home Health Quality Reporting Program Specifications for Cross-Setting Quality Measures. For those of you watching this live stream, that's in that folder number 4, and you can pull that out. So to do this activity, you need your scavenger hunt slides, and you need your technical specifications. We put this activity in specifically because often when we go out, we work with organizations or we're doing trainings. Most staff don't understand, well, what data elements go into this, or how does this measure, what is it the ultimate, why am I doing poorly in this particular measure? What questions am I answering on the OASIS that are feeding into that? What's in the numerator? What's in the denominator? I don't understand. How do things get excluded? So this is an activity that forces you to search through this document and find the answers. And what you'll find is this is a very valuable document. Not only will you use it for this measure, but for each one of the other reporting measures that come out, there will be a technical specification document. And the idea is then you'll say, well, oh gosh, I know what that is. Let me go into that document for that particular measure. Now I know that I can look for the definitions for the numerator and the denominator and the exclusions and whatnot, and how the calculations are done. So what I would like to do is everyone prepared, hopefully in your offices on streaming live, and for here that I've given you enough time to pull out your documents. What I'd like you to do is work, and you can work as teams. This is not a solo event. If you're watching live streaming, hopefully you have a partner or 2 in the area that you are watching this from. Pull out these and actually go through and start discussing and looking for these particular items. So answering the blanks in each one of these slides. So I'm going to give you about 10 minutes to do that. I'll keep an eye on the room here. And so for you watching live, we are going to start this activity now, and we'll start back by my watch in about 5 after. So why don't we go ahead and start this scavenger hunt. All right, how was that activity? Good, good. Hopefully for those of you in live streaming that you found some value in that. Strongly encourage you to read through that document and get familiar with it. But let's go through some of the answers. Okay, so our first question we have is the percent of residents or patients with pressure ulcers that are new or worsening. And we were looking at the numerator, and it's the number of patients with a Complete quality episode for which the assessment was completed at the end of care. All right. And then the denominator we have there is the number of patients with a complete quality episode, except for those who meet the exclusion criteria. All right. So the next one that we have is new or worsened pressure ulcers are determined based on examination of all assessments in the patient's quality episode for reports of stage 2 through 4 pressure ulcers that were not present or were at a lesser stage on the sock or rock, as evidenced by, and then we have the coding here. So we're starting to go through kind of all of the components that are built into your quality reporting. So you have, let me go back, we have the numerator, which we talked about, so it's looking at the complete episode, and then the denominator is all those except for if you are excluded. Whoops, sorry. All right. So again, new or worsened are the stage 2 through 4, and we're looking at the sock rock as evidenced by having a stage 2, 3, or 4 greater than 0. All right, so let's look at the denominator. So patients that blank while on service with a home health agency are excluded from this measure as they would not have completed a quality episode. Right, okay. And then patients without an assessment completed at the start of the resumption of care and an assessment completed at the end of the care are excluded, and patients are excluded if none of the assessments has a usable response. So always you'll see that caveat. If we don't have the data in there that are used to calculate the quality measure or reporting, it can't be used. So while some of the quality measures included in the quality episodes that end with a discharge, transfer, or death, the new or worsened pressure ulcer measure utilizes data from M1313, which is collected only at discharge. Therefore, episodes ending in transfer to an inpatient facility or death at home are not considered for this particular measure. So that's a caveat for this particular measure here. Hopefully that's will help clarify that denominator measure. So measure time window, it's calculated blank using rolling 12 months of data. Quarterly, correct. All complete quality episodes, except for those that meet the exclusion criteria during the 12 months, will be included in the denominator and are eligible for inclusion in the numerator. And for patients with multiple episodes during the 12-month time window, each episode is eligible for inclusion in the measure. So you may have a patient or client with multiple episodes being included. All right, and then the measure is risk adjusted based on the patient characteristics or covariance, and we're going to go into a little bit about that. And patients with characteristics or conditions that put them at an increased risk for skin breakdown or impact their ability to heal are treated differently in the measure calculations. So that makes sense, right? So if I have if I'm at higher risk for skin breakdown versus, let's say, if I'm immobile and incontinent and a variety of other things versus someone who's up and about and walking, we would think that their chance or risk of having a pressure ulcer would be less. And then risk adjustment is used to account for the medical and functional complexity of the patients. So it's trying to even or level out the various types of patients that we have and putting risk involved. So let's talk a little bit about risk adjustment covariance. Indicator of supervision/touching assistance or more at the sock or the rock for functional mobility item blank. Okay, and then let's go through and finish answering these questions. Okay, so sitting, item in lying to sitting or side of bed. Okay, so that's that item GG0170C, and that we'll go through that a little bit later on today. Indicator of bowel incontinence, at least occasionally, on the initial assessment. So these are some of the covariance or risk adjusters. They have diabetes, mellitus, blank, or peripheral arterial disease. Peripheral vascular disease, and that makes sense to us, right, clinically, for those of you that are clinical here, so that makes sense. And then indicator of low body mass index based on height, which is M160A, and weight 160B, or 1060B, sorry. on the SOC or the ROC assessment. So we're looking at a low BMI. This measure is not looking at someone with extremely high BMI. So for this particular risk one, it's saying someone who's below. All right, so those give you a sense of the covariance, the numerator, and the denominator. Now we're going to look a little bit, just so that we can walk through and you've at least heard about how do we calculate the quality measure and the algorithm. And to calculate the agency observed score, we look at calculating the denominator count. We calculate the total number of patients with a selected target OASIS assessment in the measured time window who do not meet the exclusionary criteria. So it's everyone who fits in that time frame, and then we pull out those that are excluded, and then what's left is our denominator. In simple terms, that's what that is. 2, we need to calculate the numerator count, and we calculate the total number of patients in the denominator whose OASIS assessment indicates one or more new or worsened pressure ulcers at discharge as compared to the start of resumption of care. And then the next one is we calculate the agency's blank observed score. Very good, okay. We divide the agency's numerator count by the denominator count, and we talked about that earlier, to obtain the agency's observed score. That is dividing the results of step 2 by step 1. All right, so we actually gave the example with the cookies, and then, so that was helpful. So now we have the expected score for each patient. We determine the presence or absence of a pressure ulcer blank for each patient. Covariance for each patient, exactly. We use the patient level covariance in a logistic regression. How many people know what a logistic regression is? Usually there's like one in the whole group. And okay, you don't need to know this, it's advanced math. I know what it is, I don't do well with it, and I'm just finishing up my doctorate, so that's when you hire a really good analyst and statistician and whatnot. So, but there is this process to do a logistic regression, just so we put it out there. You can talk about it over, at a cocktail party, that you can say those words, and you're going to sound really smart. But we use that logistic regression model to calculate a patient-level expected QM scores. So you think it's basically a logic model. It says, if you have this, these conditions in this many patients, you should have X on the back end. And it's the probability that a patient will experience an ulcer given the presence or absence of risk characteristics measured by the covariance. So that's the real simple terms. What are my chances of developing an ulcer if I have peripheral vascular disease and diabetes and bowel incontinence and a variety of different things, versus what are my risks if I'm up and about and have no incontinence and I don't have peripheral vascular disease? So that's kind of the simple term around that. And then step 6, calculating the agency expected score. Once an expected QM score has been calculated for all the patients, calculate the mean agency level blank QM score by averaging all patient level expected scores. So what are we saying that is? Expected, right. So we'll get the expected score once we do that. And then calculate the denominator count, calculate the total number of patients retained after exclusion and sum for the nation. Note that the sample will include only those patients with non-missing data for the component of the covariance. So basically what that says, if you have missing data in some of these items, they can't make an assumption that they know what was going on with that particular patient. So if the data isn't there, by nature of it being absent, they have to be excluded. That's all that that's saying to you. And then calculate the numerator count, calculate the total number of patients that triggered the QM, and sum for the national measure. Then we go to step 9. We divide, to calculate the national mean observed QM score, we divide the numerator count by its denominator count. Now we've taken it outside of your agency, and we're looking at it at a national level. And then you get the national observed score. This is dividing the results of step 8 by the results of step 7. So it's taking the same idea that you would do at the agency level, but now we're looking at a national level. So you have an expected score that you have in your particular agency. Now we're looking at the mean score across the nation. Calculate the agency level blank score, right, adjusted score. It sounds pretty complicated, but I think it's important that you understand that there are risk adjusters in these particular measures. They're not just straight measures, and then those will be calculated at the agency level and then at the national level. All right, so now let's get into the selected OASIS C2 items. The 1311, the current number of unhealed pressure ulcers at each stage, and then M1313, which has worsening in pressure ulcer status since the start of care or resumption of care, or the SOC or the ROC. So we're going to just a little bit document the number and stage and the status of pressure ulcers. And so we're defining pressure ulcers as localized injury to the skin or underlying tissue, usually over bony prominences as a result of pressure or pressure in combination with shear and friction. So that's an important thing. So you need to make sure what would be a key component of a pressure ulcer. What one thing would you need to be able to do if you were defining something as a pressure ulcer? Anyone have any ideas? I'm hearing a lot of different things, but do you think you'd need to be able to relieve pressure? Right? So there needs to be a pressure component of it, whether it be from a device or how they're positioned in maybe a chair or in the bed or whatever. So pressure needs to be involved with it. So this gets into, and we'll talk a little bit about this when we go through it, is when you're starting to look at pressure ulcers in areas like on the leg, and we're trying to decide, is this a stasis ulcer, or is it another type of ulcer, or is it pressure ulcer? Because you can have ulcers on legs if you have, like, you know, if you're using an AFO or something like that, and all of a sudden it's the splint that's causing pressure, okay? Where you would say normally, well, gee, if I'm having an ulcer on a mid-calf, normally it's not over a bony prop, you know what I mean? It just, you're saying, well, is it pressure? Well, if you put the splint on and the splint lines up directly with that, they're more likely than not maybe as a pressure component to it. So pressure needs to be able to be relieved. So the overarching principles, staging definitions are adapted from the 2007 National Pressure Ulcer Advisory Panel Clinical Practice Guidelines. The OASIS C2 does not preclude home health agencies from providing complete and ongoing skin assessment using accepted clinical practice and guidelines in the clinical record, and identify and evaluate risk and determine the etiology of each and all skin ulcers, wounds, and lesions to ensure that you have proper treatment. So CMS is aware, and this has come up in the other settings when we've done this cross-setting measures, that there are new guidelines. There's actually new terminology from pressure ulcer to pressure injury. And so currently, when you think about how complex our system is within all of the various settings where we are gathering, collecting data, and then publicly reporting it, I use the analogy of every time we need to change something, it's not like, oh, well, just change it like that. There's huge implications to doing that. It's like throwing a little pebble in a pond, that ripple effect. So throwing the pebble is easy. It's all the ripples that go out from that. So I know that CMS, this has been brought forward to them, they are looking at this, but I just wanted to acknowledge it, that it's not like CMS is not aware that there have been updated guidelines since 2007, and there are these other things going on. The other thing to take into consideration, and this is a caveat from me and Spinard, who's been working along with this for a long time, is that I don't know that we'll ever be 100% current. You know, when we look at the evolving change of healthcare, wound care, technologies, and whatnot, every time we go to change anything in these assessment forms and how we calculate and public report, it takes time. So, you know, it's not like we can make a decision today and change it tomorrow, so that if a new guideline came out tomorrow, could it be changed within a month? No. So will we always kind of be a little bit behind? I think so. I think the caveat that is in this slide says it doesn't preclude you in your organization, if you want to start calling things pressure injuries, that's okay. Call them pressure injuries. Use the current standards, guidelines, and practices in your clinical practice, and then just use the guidelines that are provided in your manual on how to code the OASIS tool. So hopefully that is helpful to you. So M1311, current number of unhealed pressure ulcers at each stage. So what we're looking at here is the OASIS C1 item as compared to the C2 item. And so we looked at C1, it says the current number of unhealed pressure ulcers at each stage are unstageable. And then the new item, which is now coded a different number. So if you had these committed to memory, as many people have, it goes from 1308 to M1311, and it's the current number of unhealed pressure ulcers at each stage. So there's, it's going to take a little bit of time maybe for your staff, thinking about the numbers and whatnot. So you want to make sure that everyone understands that it's not dramatic change, but there are some changes. What I wanted to show you here in the next two slides is this the current way when you go into your assessment form, how it is presented. And then when you look at the OASIS C2, and this is not meant for you to read because it's teeny tiny up there, but this is what you're going to see if you were looking at a screenshot of the tool. And we're going to go through item by item so that you'll be able to clearly see this. So it's important, again, for staff to understand that it's going to look different. So think about that from your action items. How are you going to educate your staff just to make sure they understand the change in the numbering and how it's going to look so that staff do not get distressed over this process. So M1311, item intent, it identifies the number of stage 2 or higher pressure ulcers at each stage present at the time of the assessment. And stage 1 pressure ulcers and pressure ulcers that have healed are not reported in this item. So if you have a stage 1, that doesn't mean you shouldn't clinically address it. Okay? Please remember that. It's just saying you're not going to report it off on this. And certainly if you have a healed pressure ulcer, again, you're not going to report it here, but I would hope that you're going to engage with that in your care plan, right? And what you're going to do to help prevent and make sure that that particular item or area doesn't open again because it's at higher risk. So the time points to complete this are at the start of care, your SOC, your resumption of care, your ROC, your follow-up day, which is your 60-day assessments, and then discharge from agency, not inpatient, and not discharge to the inpatient or death. And when we look at the time frames for completing this, when the assessments, and we're going to talk a little bit about this in some of our scenarios, just remember your time frames when you're trying to encode these particular items. So your start of care, the assessment should be completed within 5 days after the start of care, and then your ROC, of course, is 2 days. Your follow-up you have within that 5-day window, and then discharge from agency within 2 days. I'm not telling you anything you don't already know, but I just wanted to remind you of that. Okay, so let's talk a little bit about actually going in and starting to code these. So terminology referring to healed versus unhealed ulcers refers to whether the ulcer is closed versus opened. So who here has dealt with pressure ulcers from a kind of a clinical perspective? It's a few of you. So I want to just spend a second on explaining this for you that maybe are not so clinical oriented or haven't done this in a long time. So when we say it's healed versus unhealed, we're saying whether it's closed. So meaning that the skin has completely closed. But what can happen, and any of you who have dealt with pressure ulcers, is sometimes the skin closes, but the wound underneath hasn't, the tissue underneath hasn't healed. So the skin piece, the epithelialization has happened, but actually we haven't had wound healing from the bed up. And then, of course, for those of you who have gone into a little bit more detail around wounds, you know that even when it's completely healed and whatnot, the tensile strength, the actual strength of that skin and the structure below it is at its maximum 80% of what it was before it ever became a pressure ulcer. So it's never as good as the skin we were born with, okay, the original skin that we had. So you could say something close, and then it can open up if we don't pay attention, and it can open up and be kind of that gaping wound underneath, and so we've seen that. So stage 1 pressure ulcers and suspected deep tissue injuries, although they're closed, okay, so if you have a stage 1, and we know that that's a kind of a persistent red area, non-blanching, and then, or suspected deep tissue injury, meaning it's usually that purpley dark color to it, although it's closed, so the skin's not open, it wouldn't be considered healed. We don't know what it is going to be, especially if it's a suspected deep tissue injury. We don't know when it decides to declare itself, what is it going to look like. So even though the tissue is closed, it's not considered healed. And then unstageable pressure ulcers, whether covered with non-removable dressing, eschar, or slough, would not be considered a healed ulcer either. These are subtleties, but important to make sure that your staff understand as they go out and they complete the OASIS, especially in home care, because you may have many, many nurses completing the OASIS. Is that correct? Right? Okay. As compared to an inpatient rehab facility, a long-term care hospital, or a skilled nursing facility, where you have far fewer people who are actually encoding the assessments. So you have this tremendous workforce, and you've got to train a whole lot of people and make sure that they understand how to accurately assess and then code the OASIS, as compared to probably a much smaller number in some of the other settings. So I think your job is a little harder and far-reaching, but just as important to make sure that they understand all of these subtleties. Then we want to look at present on admission. Equals for you in home health means at the start of care or resumption of care. For each pressure ulcer, determine whether the pressure ulcer was present at the time of the most recent start of care or resumption of care and did not develop during the home health quality episode. So this is really important to get out, to assess, and to know exactly what your patient looks like when you take them on to service. Patient assessments are completed as close to the actual time of the start of care, resumption of care as possible. And if a pressure ulcer that is identified on the start of care date increases in numerical stage or worsens within the assessment time frame, the initial stage of the pressure ulcer would be reported in M1311 at the start of care. So let me explain some of these bullet points here. So again, this is a cross-setting measure. So these questions actually came up in some of the other healthcare settings. So if I'm in an institution, I'm in a building, right? So I'm in a skilled nursing, I'm in an inpatient rehab facility, or a long-term care hospital. We have nursing care 24 hours a day. I may have done your skin assessment within the first 8 hours of you being in the walls of my particular facility. So let's say I assessed you as having a stage 2 on your coccyx. Now, 3 days later, I go in, and I'm still within my 5-day assessment period, but now your stage 2 is going to a stage 3 because it's, partially covered in slough. So what do I do to code? Well, that's where this caveat came in. You have to do with the closest to when they came in to your organization. So think about your setting. Think about home health. So if your RN is going out to do your assessment, and they go out within 24 hours of discharge from, let's say, the acute setting, and you do an assessment, and for some reason you're back out there 2 days later or 3 days later, so you're within that 5-day window. If something has changed in that wound, what we're saying here is please encode what you found on your first visit. That's what this is saying to you. The writing around this is really, trying to straddle two kind of environments. The structured kind of four walls environment, and then home care, which has its own challenges. For the stock or rock, you want to enter response for rows A1 through F1. You want to enter the number of pressure ulcers that were currently present. And if you don't have any pressure ulcers on that particular stage, just go ahead and please enter a 0. In this, at follow-up or discharge, enter the responses, and what you'll see is we have A1 and A2 and B1 and B2, and we're going to go through these in more detail. And so A1 through F1 is enter the number of pressure ulcers that are currently present. So we're looking at, let's say it's a follow-up at 60 days later. What do I see now? and enter 0 if there's no pressure ulcers. And then A2 through F2, enter the number of pressure ulcers that were present on admission. So it will say, of these ulcers, how many of these were present when I did my start of care or my resumption of care? And we're going to go through those in detail. But that's where we're looking at for those assessment. So we have the stage 2 pressure ulcers, and this goes through and it defines it as a partial thickness loss of dermis, presenting as a shallow open ulcer with red-pink wound bed without slough, and also may be present as an intact or ruptured blister. These haven't changed for you. Those have been there. And so the important thing is, and I'm going to go through this in each one of these as we go through from a stage 2, 3, 4, and 5, is are you confident, as you sit here today, that all of your nurses that are completing the OASIS are competent in assessing skin? You don't need to raise your hand. Do a little soul searching, think about it. Is this an opportunity for some improvement? Because this matters, okay? So this is going into the quality reporting system. So if I say that I have a nurse who goes out and encodes and says the person has a stage 2 pressure ulcer on their coccyx, and then they describe in a narrative type note that the wound has some slough, and not completely occluding it, but that ulcer has some slough in it. Can it be a stage 2? No. Are you confident that all your staff know that? No. Good, you're being honest. Because guess what? That's probably the biggest caveat or the hardest areas from those, from between stage 2 and stage 3s. So you want to make sure, unless they're an obvious stage 3, much deeper and whatnot, but you can't have slough in a stage 2. So take the opportunity to make sure that your staff truly understand. And you can use some scenarios that we're going to go through here, and think about some of the other education that you can do in your particular facilities to make sure that your staff really understand what they're looking at and what they are actually capturing. So if you're doing some quality audits, does anyone do quality audits of their records? Of course you do, right? So are you looking at that detail, though? Are you looking at what's coded on the OASIS versus what's documented maybe in the clinical record? And if there's an opportunity, where you really see it usually is in a clinical note of some sort, where they're describing what they're seeing. That's where you might find a great opportunity to do some education. And if it's just a couple of staff members, go ahead and educate just a few staff members. But if it's kind of a system-wide hit or miss, take the opportunity to determine some of the competencies within your staff around these particular areas. All right. I've done preaching for that, so. And I've preached to every group because I've taught this in each one of the settings, and so I've preached to all of the groups on this. They've all heard the same messaging. All right, so stage 3 talks about full thickness tissue loss and subcutaneous fat. Fat may be visible, but not bone and tendon. Slough may be present, but does not obscure the depth of the tissue, so you can see to its deepest point, and then you can go ahead and code this as a stage 3. And we just talked about that. And then stage 4, those are the most unfortunate, but it's full thickness tissue loss with exposed bone, tendon, and muscle. And just remember that in this particular, it could include undermining and tunneling, and actually stage 3 can have some undermining and tunneling. And if any bone, tendon, or muscle or joint capsule is visible, the pressure ulcer should be reported as a stage 4 pressure ulcer, regardless of the presence or absence of slough and or eschar. So you could have a little bit of eschar, a little bit of slough, but if you see bone, it's a 4. There's no question about it. If you see bone, okay, it's or an attendance. So, but think about this, and this is where staff struggle a little bit too. Think about the outer malleolus, the ankle. Like there's not a lot there, right? It's different than if you get to a hip, and stuff where you have maybe a little bit more padding to get through. So you can get to a stage 4 pretty quickly in those particular areas versus maybe in the sacral area. So again, making sure that we have staff that understand how to code it. So let's go into a little bit around the unstageables. So unstageable, non-removable dressing or device. And what we're looking at here is that you know that there's something there, but it's not stageable due to you can't remove the dressing. And something might be that they have a cast. They could have some sort of a primary surgical dressing that you don't have orders to remove, so you can't, you want to peek under it, but you can't and take a look. So you know something's going on there, but you yourself can't put eyes on it to determine what it is. So we're saying that you have something there, but it's unstageable due to the fact that you can't remove the dressing. At a later date, hopefully the dressing will be removed, the cast removed, whatever it is that it's obscuring your ability to take a look at it will be removed, and then you can actually code whatever stage that you find it at. So they can be a primary, I talked about this, primary surgical dressing, orthopedic device, a cast, or whatnot, and it's just that you have an order that you can't remove that. So let's talk about slough and eschar, and I think this is an item that you were always answering, but unstageable because the wound bed is covered and you can't see to its deepest anatomical point to be able to clearly be able to determine what stage the pressure ulcer is. And here we're looking at, so the true anatomical depth of the soft tissue, you can't see it, you can't determine it. The pressure ulcer stage can be determined only when enough of the slough is removed. So if I had something that was completely covered with slough or eschar, and then it got chemically or surgically debrided, and all of a sudden I see bone, well then I can code it at that point as a stage 4, but prior to that point I can't say, I don't really know what's underneath. And just to go through and to make sure everyone understands what we're talking about, so slough is non-viable, yellow, tan, gray, green, brown tissue. It's stringy, it's sticky, it's yucky. It doesn't easily clean off. And it's adherent to the base of the wound and present in clumps throughout the wound bed. These are wonderful things to talk about before lunch. I just thought I'd tell you that. You are lucky that I'm not showing pictures, because I usually do things like that, and people are like, oh. We actually talked about that. Should we add pictures during this training? And we're like, not everyone's a nurse. Like the nurses would be, oh, that's cool. I like that. It's neat. And everyone else would be going, oh, I'm nauseous. It's interesting in our offices as we've done a lot of trainings, we have support staff and they're like, oh, do I have to do that? Do I really have to look at those pictures? Anyway, so eschar is dead or devitalized tissue. It can be hard or soft in texture. It's usually that black, brown, or tan in color, but it's more like a scab. I think that's a good example to use kind of eschar. It's just it's really stuck on. It's necrotic tissue. It's usually firmly adhered to the base of the wound and often the sides of the edges of the wound. And so both are used to say, I don't know what's underneath. I may suspect that I know what's underneath, but until you surgically or chemically debride that and get rid of it, I have no idea whether I'm dealing with a stage 3 or a stage 4. We know it can't be a stage 2, right? Right. So we know it's at least a 3, but we don't know if it's a 4. So just remember that. And then we have this unstageable suspected deep tissue injury. And we talked a little bit about this earlier. And suspected deep tissue injury are purple or maroon area of discolored intact skin due to damage of underlying tissue. And a very common place that we see suspected deep tissues is the heels? Yes, very common in the heels. The area may be preceded by tissue that's painful. It may be firm or mushy. It could be boggy or warm. It could be cooler. So it could be, really what you're saying is there's something going on with the tissue surrounding that particular area. Now, the other thing to remember is deep tissue injuries may be difficult to detect in individuals with darker skin tones. So when you think about someone who has very dark skin tones, a suspected deep tissue would be much harder to pick up on them than, say, myself, who I'm very pale. And so you would pick up purpling, dark color on me very easy. With someone who has a lot of melanin or dark skin, it could be really hard. So you've got to look, and you have to look with really good light in the areas that you might suspect that you would see some of these injuries. And you might, really, that purpley hues and stuff could be really hard to pick up. So make sure that you, your staff, again, are educated in doing that. And evolution may include a thin blister over a dark wound bed. The wound may further evolve and become covered with a thin layer of eschar. And evolution may be rapid, exposing additional layers of tissue, even with optimal treatment. So the thing about a suspected deep tissue injury is, until, I call it declaring itself, until it tells us what it really is. So we see a purple area. We don't know if that's superficial damage or how deep that damage. Think of it almost like the tip of an iceberg. And until it opens up and tells us what it is, you know, I've seen areas, especially in the heel, where that purple area just really just continues to stay purple, and it ultimately just kind of reabsorbs and goes away. Then I've seen those heels go to eschar, okay, that thick, leathery brown, and then you do everything you need to do, and over time, it's like a scab, little pieces fall away, and by the time the escar's gone, you see this healed skin underneath, right? And I've had others that have opened up, and you're right to the bone. So you really don't know what you're going to get as these evolve. But they are important, and we need to pay attention to them. Okay. So what are some of the data sources or resources that we can use when we're trying to understand someone's skin condition? Patient or caregiver interviews. And those would be important for you to know about history. If someone had a history of pressure ulcers, oh, gee, my mom had a really bad hip pressure ulcer, and it was 2 years ago, and it's healed, but you know, that skin's never been the same. And that family member's right, that skin will never be the same. But that's important for you to know when you're going to go in and care for that person, going to keep a close eye on that. Certainly your observations are critically important. What does your physical assessment show? So are you doing a good assessment? What is your clinical record telling you? So what's your transfer documents, whatever information that you're getting from the previous care setting, including your referral documents? What's your physician telling you? Hopefully your physician has seen the patient and know what's going on. So your primary care may not have been the person who saw the patient. It might have been your hospitalist, or could have been your SNF or SNFist, whatever they're calling them now, or from the previous setting. What kind of documentation are they sending along? And then there's additional resources in Chapter 5 of the OASIS Guideline Manual, which will help guide you in this. But think about, in your own agency, where would your staff find some of the documentation, short of them going out, which they need to do anyway, and their own eyes and what they're assessing? What other documentation? Where else are they going to find information in your record or transfer documents? And then do they have access to those, and can they look at those and then validate what they're seeing when they go out to your patient? All right, M1311. So let's look at this. A previously closed stage 3 or 4 pressure ulcer that is currently open again should be reported at its worst stage. So think about that. Do we reverse stage? No. We did in skilled nursing for a lot of years. So we had to change that practice. Actually, the MDS required at one point that we had to reverse stage. Of course, a stage 4 is always a stage 4, right? So if it was a stage 4, and think about that earlier example that I gave you where the skin closed over on it and then it opened up again, okay? Even if it was a stage 4 and you knew it was to the bone, now it opens up and it looks like a stage 3, okay? So it's not quite down to the bone. Once that reopens, that exact same area is a stage 4. So are you confident that your staff would code that way? That's a good one, right? Would they code it as a stage 3, what they're seeing? So think about that. How is that going to work in your particular agency? If the patient had been in an inpatient setting for some time, it's conceivable that the wound has already started to granulate, thus making it a challenge to know the stage of the wound at its worst. The clinician should make every effort to contact the previous providers to determine the stage of the wound at its worst, and the ulcer can worsen, and this item should be answered using the worst stage if this occurs. So it's really important that if someone's coming to you with a stage 3 ulcer, that you can verify that it was never worse than a stage 3. Because if they've been from an acute care setting to, let's say, a skilled nursing or inpatient rehab facility or a long-term care hospital where they're going to have longer lengths of stay, now they're coming out to you and you're doing home care. That wound could be very different than what the clinician is seeing from what its original stage was. So think about that. How do we ensure that we understand, you and the home care agency and your nurses understand what the worst stage of that ulcer was? So we looked at, there was a variety of questions that came in during my session for the last hour before lunch. What I'd like to do, I'm going to address some of these, but what I'd like to do is finish, if I could, the presentation. I think some of the questions are going to get answered as I go along, but then I will recap with the questions that we have and the answers to make sure that you have the information that you need to move forward. Okay, so we are going to pick up from where we left off. Let me just go to the next slide here. A couple of key things, and these are just tips around M1311. If someone has a muscle flap, a skin advance flap, rotation flap, or any one of those things, to surgically replace the pressure ulcer moves from being a pressure ulcer to a surgical wound. And it would not be reported as a pressure ulcer after that procedure in 1311, okay? So you could have had the pressure ulcer, now they have the surgical flap, and now it becomes a surgical wound. And then a pressure ulcer treated with a skin graft should not be reported as a pressure ulcer until the graft edges completely heal. Should be reported as a surgical wound in M1340. And then a pressure ulcer that has been surgically debrided remains a pressure ulcer and should not be reported as a surgical wound. So we have two kind of examples where something was a pressure ulcer, had these procedure, now is considered a surgical wound, but if we are just doing a surgical debridement of that pressure ulcer, without doing a flap or anything else, it still remains a pressure ulcer and should not be coded as a surgical wound. All right, so we're going to actually go through and do some practice scenarios, and I think this is where we start to apply, and I think this is where we're going to answer some of the questions that already have come up, both from the room and I think online, so hopefully you'll find this helpful. So we have a practice scenario here, and so we'll look at the scenario together. So at the start of care, the patient has 3 small stage 2 pressure ulcers on her sacral area. Actually, I think there is a form in the download section, and you should have it in your folder for coding scenarios. It's just basically we took the portions of the item set. I think it's on your right-hand side if you're in the room here. So you'll see section M. Can everyone find it? I'm sorry, I don't have a copy of it. Do you have it there, Anila? So I can. So I don't know if those are watching on live streaming, if you can see this, but it's the Home Health Quality Reporting Program, M1311 and 1313 practice scenario sheets. That's the title of it. Looks like this, has lots of little boxes on it. If you can pull that out, it would be very helpful as we go through some of these practice scenarios. Has everyone found it? Hopefully those of you who are on live streaming can pull this out also. So it is stapled, so it has multiple pages to it. It was in your folder. It's definitely there. I'm looking around the room. I think some people are struggling. Has everyone got it? Okay, great. All right, good. So just keep that handy as we're going to, and use this with this coding scenario. So here we have at the start of care, you assess the patient, and they have 3 small stage 2 pressure ulcers, and this patient happens to be female, on her sacral area. Upon discharge, the sacrum is assessed, and 2 of the stage 2 pressure ulcers have merged, and the third ulcer has increased to a stage 3. So we have a practice scenario. So we're going to go through this, but if you can take out your coding sheet and let's code these items. I'm going to give you just a second to code it, and then we're going to go through the answers. So this is what you're going to be looking at. This is what you should have on your paper. For those of you live streaming and you haven't pulled this down and you might get frustrated, just take a scrap piece of paper and then just code these along with us. All right, everyone have written down your answers? All right, so let's look at this. M1311A1, the number of stage 2 pressure ulcers, and this is the start of care or resumption of care. What are we going to code there? How many ulcers? 3. Very good. Okay. So we look at that and we have stage 3. Then we're looking at the number of stage 2 pressure ulcers at discharge. How many do we have? I hear 1. Does everyone agree with that? I hear some 3. But how many? So this is discharge. So on the start of care or resumption of care, we started off with 3 stage 2 pressure ulcers. And now we're at discharge. How many do we have? 1. Good. So we have 1. All right. So we have 1 stage 2. And the reason for that is that we had 3 stage 2s to start with, but 2 of them merged together. So when they merged together, they haven't increased in depth, okay? But those 2 became 1. Sometimes you'll have that small little band of skin that separates them. Now that skin is gone. If not increased in its staging, but now those 2 stage 2 ulcers have become 1 stage 2 ulcer. Okay, that's where that scenario comes from. All right, the next question is M1311A2. So the question is asking the number of these stage 2 pressure ulcers that were present at the most recent sock rock. So read the question carefully. The number of these stage 2s, and when they're talking about stage 2s, they mean the ones that you just talked about, okay, the previous question. So the number of these stage 2 pressure ulcers that were present on the most recent sock rock. So I hear 3. What else do I hear? 1. Okay. So let's talk about it. The answer is 1. Now, let me explain to you why, because this is important. So what we're looking at here is 1311A2 says, because of these ulcers, so we said there was 1 stage 2, okay, at discharge. Then it's saying to you, of those, how many were present at the start of care or resumption of care? Okay, so it's looking at the question before it, right above it. Of the 1 ulcer that I had, how many of those were present at the sock rock? And it's saying 1. It could be 0, right? It could be that it developed. All right, so it's saying I have 1 at discharge, but it wasn't there at the start of care. All right, so the answer could be either. But there's a subtlety there, but that's what we're looking for in that particular question. All right. Oh, I gave you the answer. Sorry. Okay. So the number of stage 3 pressure ulcers, so that's 1311B1. The number of stage 3 pressure ulcers at the start of care. Right. They didn't have any, right? They didn't have any. They came in with 3 stage 2s. Now the next question, remember that's a follow-up question. So it's saying the number of these stage 3 pressure ulcers that were present on the most recent sock rock. I'm sorry. So I'm sorry. The number I went down the next row. I'm sorry. So let me go back. So we started off with the number of stage 3 pressure ulcers, and we're looking at the sock rock, and that was 0. Then we go across to the right, and we say the number of stage. And this is the discharge assessment. So we had the start of care assessment, and now we have the discharge assessment. The discharge assessment says the number of stage 3 pressure ulcers that we had. 1, right? my error in doing that. I was jumping ahead. Then the next question says, now we're looking at the discharge assessments. So we're looking at we have one stage 3. The number of these stage 3 pressure ulcers that were present on the most recent sock rock. Right. Because they didn't have any, all right? So think about these. The first column there was looking at the start of care, resumption of care, and then as compared to, we're comparing the two assessments at the discharge. All right, we're going to have more opportunities to practice. All right, so and then the rationale behind this, 2 of the pressure ulcers on the sacrum have merged, but have remained at the same stage as they were at the start of care. So M1311A1 is coded as 1 at discharge. The pressure ulcer that increased in numerical stage to a stage 3 has developed a deeper level, okay? So it's advanced in its tissue damage since the start of care. Therefore, on the discharge assessment, M1311B2 is coded as 0, not present on the start of care or the rock. So that's the rationale behind that. I would encourage you, as we go through these, you can take these back to your own organization. You can use these, or you can use your own patients, and you can do similar type of education for your nurses to make sure that they've got the subtleties around this. All right, if you take your form that we were doing the practice scenario sheets, and you go to flip it over and go to your next scenario. So now we're looking at scenario 2. So at the start of care, Mrs. J is admitted with 4 stage 2 pressure ulcers and 1 stage 3 pressure ulcer. During Mrs. Jones' home health quality episode, 3 of the stage 2 pressure ulcers healed. However, Mrs. J developed an additional stage 3 pressure ulcer. So a slightly different version. And if you look at your form here, your practice scenario form, it's got the key elements already that we just talked about. I'd like you to just take a second and code your form. For those of you at home, or not at home, but on the streaming video, again, you can just write these on a scrap piece of paper if you haven't pulled down the practice scenarios. Just give it a moment. People are diligently answering. Okay, so for the first question, 1311A1, number of stage 2 pressure ulcers on the start of care are the sock rock? 4, correct. Okay, the next question is the number of stage 2 pressure ulcers at discharge? 0, 1, 2, what are we hearing? 2, okay. So it's actually 1, okay. So let's talk about that. At the start of care, Mrs. Jones was admitted with 4 stage 2 pressure ulcers, so that's how we got our first answer, and 1 stage 3 pressure ulcer. During her home health quality episode, 3 of the stage 2 pressure ulcers healed. So she had 4. We take away 3, and it leaves us 1. We wrote this in a little bit of a confusing way, right? So you need to peel back the onion and make sure you're understanding the pieces, okay? So there was 1 stage 2 left. All right, so the next question says, the number of these stage 2 pressure ulcers that were present on the most recent sock rock. Right, and we just kind of explained that, right? Okay, exactly, code 1. The number of stage 3 pressure ulcers at the sock rock. I hear 0 and 1. What do we think? 1. Majority says 1, and that is correct. But why is that correct? Well, we said she had 4 stage 2 pressure ulcers and 1 stage 3 upon admission, right? Okay, so that's how we get the answer there. So on admission in the sock rock, she had 1. All right, so the next question says, number of stage 3 pressure ulcers at discharge. Okay, you guys are good. All right, so they had the original 1 on discharge, right, that they had when they started care, and then they developed an additional 1. All right, so now we had 2. Very good. The number of these stage 3 pressure ulcers that were present at the most recent start of care or sock rock. You got it, okay. You coded as 1. Very good. And so there were 4 stage 2 pressure ulcers on the sock, but prior to discharge, 3 of the stage 2s healed. That left us 1. And then they had 1 stage 3 upon admission. They continued with that 1 stage 3, and then they had an additional stage 3 ulcer that developed. And that's how we came up with our coding. Getting it now? Okay, great. So we have now, I'm sorry? Okay, so we're having some questions. So 1311B2, you have a question on? Okay, so let's spend a second on 1311B2. So what it's saying is the number of these stage 3 pressure ulcers, so we're saying we have 2, this is the discharge assessment. We're saying now we have 2 stage 3 pressure ulcers, right? Then it's the follow-up question is saying, okay, so you have 2. How many of those pressure ulcers, those stage 3 pressure ulcers, were on the sock rock? 1. So that leaves us 1 left, right? 1 that wasn't there when we started. Do you see how the follow-up questions are referring to the previous coding? Does that answer the question to the room? Yes? Okay, clarifies it, great. All right. We talked about the rationale. All right, so we have practice scenario 3. So if you go to your practice scenario 3 on your handouts, that would be great. So in this scenario, at the start of care, Miss P was admitted with the diagnosis of a stroke with a right hemiparesis and assessed to have a 1 centimeter by 1 centimeter by 0.1 millimeter stage 2 pressure ulcer on her coccyx. Mrs. P continued to decline at home with decreased appetite, frequent TIAs, and a wish not to be hospitalized again. After a palliative care consult, the patient and family agreed to hospice care. Upon discharge from home care, Mrs. P was noted to have a pressure ulcer covered with eschar on her left heel and a stage 3 pressure ulcer, 3 centimeters by 2 centimeters by 0.4 millimeters on her coccyx. So I'm going to give you a second. This one's a little bit more involved. And we're going to do this practice scenario. So I'm going to give you a moment because there's lots of questions to answer. Remember, all the information, if you're following along on the sheet, all the details around the different types of ulcers is on the top of the scenario case. Okay. How's everyone doing? Just give it another moment. People are still diligently writing. Just give it another moment. So you see how much time it's taking to think through this? So make sure your nurses can do the same thing. This would be a good scenario to use in training. Okay, and trying to stick to schedule. We've got a lot more to cover. Let's go through the scenario. Okay, so let's look at the first item, the number of stage 2 pressure ulcers present upon start of care. Okay, great, 1. So now let's look at the next thing, the number of stage 2 pressure ulcers present at discharge. 0, they didn't have any at discharge. Now, so then the next question, and we haven't talked about this before, so the next question says, the number of these stage 2 pressure ulcers that were present at most recent sock rock. What would you do here? Actually, it's a skip pattern. It was a trick. So think about this. If you're doing this in an automated system, it would skip you down to the next question, all right, because it's asking of these, and you're saying you have 0, so you can't say of 0 what you had present. So really, this would be a skip pattern. So we're showing it here. It would be probably seamless for you in electronic health record. It would just progress you to the next question. The number of stage 3 pressure ulcers upon admission, start of care, or resumption of care. Okay, great, 0. And then how about at discharge? And we're looking at stage 3. Very good, you guys are good. All right, number of these stage 3 pressure ulcers that were present upon the most recent sock rock, right, 0. All right, the next question is number of stage 4 pressure ulcer sock rock. Okay, and how many of them at discharge? Correct. Okay, so then the number of the stage 4 pressure ulcers that were present on the most recent sock rock? Skip. Remember, that's a skip pattern. Because we had 0, we're going to skip through. We don't have any to look at. So now we're starting to get into some of the unstageable questions. So the number of unstageable pressure ulcers for non-removable dressing for start of care. 0. We didn't have any, and this is because of non-removable dressing. Specifically non-removable dressing. Okay, so that cast, things like that. All right, and then how about at discharge? Right. So they didn't have, and this is specifically related to non-removable dressing. All right. So then the next question says number of these pressure ulcers that were, let's see, yeah, the number of these unstageable pressure ulcers that were present at most recent sock rock. Skip. Skip, skip, skip. Okay. Then we're looking at the number of unstageable pressure ulcers for slough and eschar on the start of care. Right. Then how about at discharge? Correct. Number of those unstageable pressure ulcers due to slough and eschar that were present on the sock rock. Right. Okay, it wasn't there when you started. And then number of unstageable pressure ulcers, suspected deep tissue injuries on sock rock. Right. How about at discharge? 0 is correct. So this is specifically looking at suspected deep tissue. Suspected deep tissues. So there's 3 different ones that you're looking at, okay? Unstageable due to non-removable dressing, unstageable due to eschar slough, unstageable due to suspected deep tissue. Those are 3 separate questions that you're asking. All right, and the number of these unstageable pressure ulcers that were present on the most present sock rock. Right. We actually have a 0 here. That's wrong. It should be a skip. Okay. So very good. So we went through a lot. That's kind of a detailed one. It's probably a good training scenario to use with your staff. So in the rationales, the stage 2 pressure ulcer on the coccyx was present on the start of care, but deteriorated to a stage 3. And then Ms. P also developed a new heel pressure ulcer during her home health quality episode that was unstageable upon discharge due to eschar. So that just gives you a sense about answering some of those questions. So M1313, worsening in pressure ulcers since the stock rock. And what we look here in the OASIS C1 items, 1309 had worsening in pressure ulcer status since sock rock. M1313 is worsening in pressure ulcers status since sock rock. So you'll notice it went from 1309 to 1313 and expanded. What we have here were the screenshots from the OASIS C1. And so I think to note here is that you only were coding unstageable due to the wound being covered by slough or eschar in C1, and this is changing on OASIS C2 to this is your item set So what we've highlighted there in the yellow are the 2 additional areas that we're looking at unstageable. So the 2 new ones are unstageable due to non-removable dressing. And then you already have been doing unstageable due to eschars and slough. And then we have F, which is new, which is unstageable due to suspected deep tissue injury. So when you go back to your organizations or you're starting to think about implementation and getting people up to date with all the new guidelines, you want to make sure that you focus on the new items. But take the opportunity to validate that everyone was doing it right anyway. If you're going to bring them in for education or you're going to do some education, make sure that they understand kind of all the things that we've talked about today. The item intent is to document the number of pressure ulcers present at discharge that were not present, or another way to think about that is new. So if it wasn't present, it's new. Or worsened, meaning it's increased in numerical stage, since the most recent start of resumption of care. If a pressure ulcer increases in numerical stage from the sock rock at discharge, it is considered worsened and would be included in the count of worsened pressure ulcers at M1313 at discharge. And we're going to go through some examples on that. The time points for completion: discharge within 2 calendar days of the date of discharge, transfer, or death. So let's go through. You want to steps for assessment: review the history of each current pressure ulcer, compare the current stage at discharge to past stages to determine whether any pressure ulcer currently present is new or at an increased numerical stage when compared to the most recent sock rock. Remember, we don't reverse stage, okay? So if something gets worse, that's fine. But if it's a stage 3, it's a stage 3 until it's closed. Then for each current stage, count the number of current pressure ulcers that are new or have increased in numerical stage since the last sock rock that was completed. Okay. For pressure ulcers that are currently stage 2, 3, or 4, rows A, B, and C, mark a response for each row of this item. If at discharge there are currently no ulcers at a given stage, you want to enter 0 for that stage or row. So if it's asking you for stage 2 and they don't have any stage 2, you're going to put a 0 in there. Report the number of current pressure ulcers at each stage that are new or have worsened since the most recent sock rock. So we're going to go through here. So this is some scenarios, and what we're looking at here is reporting algorithm for M1313. So a stage 2 at discharge, if the same pressure ulcer at most recent sock rock was not present, if it was a stage 1, if it was covered with a non-removable dressing device, then documented as a stage 1 or at a higher a home visit or follow-up assessment, then you report as new or worsening. So let me give you some caveats around this. So if an ulcer on the start of care is covered with eschar, non-removable dressing, or a suspected deep tissue injury, when it first, identifies itself, so now we're able to remove the, let's say, the device, and you say, oh, okay, it's a stage 2. We're going to record this now as a stage 2. Yes. And then when you go through the rest of these, the stage 2, the answer would be no on the next one. Stage 3 or 4, it's not applicable. We don't have any. And then covered with a non-removable dressing, well, we'd say no because that non-removable dressing component is gone. And then if you go through these, it takes you through, these algorithms take you through each one, the same thing. If it was, if the staging, we're looking at a stage 3 at discharge, if it wasn't present, if it was a stage 1 or 2, or it was unstageable and now you can stage it, we're going to code it as a yes. Okay, and then stage 3 would be no, stage 4 would be NA, and then unstageable until assessed as stage 3 at discharge, no. So there's an algorithm for each one of these. We're going to go through stage 4, and then the unstageable. So again, these are looking at the discharge assessments. Here's one for non-removable dressing. So it was unstageable due to non-removable dressing. If the same pressure at the most recent to Sock Rock was not present, then we answer yes here. So, and we do the same thing for slough and eschar, and the same thing for deep tissue. So let me just go, and we're going to go through some practice scenarios. I think that's the easiest to gather this data. So let's talk about the use of the dash at 1313. A dash value is a valid response for these items. A dash value indicates no information is available or an item could not be assessed. This most often occurs when the patient is unexpectedly transferred, discharged, or dies before the assessment of the item could be completed. So, if suddenly they die, or you haven't had, you haven't had the opportunity to do this, you can put a dash. And CMS expects the dash to be used in a rare occasion. So more likely than not, on almost all of these assessments, you will be able to code. But if for some reason you didn't have the data, you couldn't, and they could not be assessed. And I'm not saying couldn't be assessed because it was covered with a dressing, a non-removable dressing. But here you just didn't have the opportunity to assess it. You'd have to put a dash. And I think a dash is new for home health. Yeah, okay. You use the dash, let me just, in caution, you use the dash very judiciously, but it is a valid response, but it's only used if you've exhausted all efforts to be able to get the information, and then you use a dash. Some of these tips we've already talked about. Don't reverse stage pressure ulcers as a way to document healing, as it does not accurately characterize what is physiologically occurring in the ulcer. And some of the kind of questions and discussions that we had during the break were, well, wait a minute, what happens? I'm assessing it, and it looks like a stage 2 or 3, but it was a 4 from the previous setting. It's a 4 until it's closed, right? We talked about that earlier. So if you have, documentation from the previous setting that it's a 4, and your nurse goes in and looks at it, and they're like, well, it's not a 4, it's a 3. But you have documentation that says, this was a stage 4, it is a 4, and that's what you need to code. And it will be a healing 4. So clinically, you may be looking at something that's healing, that clinically looks to you like a stage 3, but we know its worst stage was a stage 4. So until that is closed, it continues to be a stage 4. And then once the pressure ulcer is fully granulated and the wound surface is completely covered with new epithelial tissue, the wound is considered healed and should no longer be reported as an unhealed pressure ulcer. So some of the questions and comments that came up during the lunch break around this was, well, wait a minute, we used to code this if it was a healed or closed stage 3 or 4, we used to count that. And so the instructions here, you don't count that, okay? Even though you know it, you clinically want a care plan for it, but we're not going to count it if it's healed and no longer to be reported. So that's a clarification point. So if that's a change in practice for your staff, you want to make sure that they clearly understand that. A previously closed stage 3 or 4 pressure ulcer that break down again should be staged at its worst stage. So if it was a 4, so let's take that scenario of that person who was a 4, maybe in the skilled nursing facility. It's healing. Your nurses are looking at it and they're like, wow, this is great. It's healing beautifully. It's still a stage 3, okay? But let's say during the care it completely heals, which would be awesome, closes. And then if it should open again, so it closed over, and now it opens again, it goes right back to being a 4, okay? Not maybe it looks like a 2 to you or the nurse, or back to that 3, but it goes back to, because we know it was originally a stage 4. If the pressure ulcer was unstageable for any reason at the most recent Sock Rock, do not consider it new or worsened if at some point between the Sock Rock and discharge, it became stageable and remains at the same stage at discharge. So let me explain this one a little bit. So a patient comes in, they have a wound, let's say, that's covered with a eschar. We don't know what it is, so it's unstageable due to eschar, right? Slough or eschar. Now, while they're in care, they're not discharged, you're still caring for them. Let's say you do some sort of chemical debridement. The slough's gone, and you can stage the ulcer. So you stage that ulcer, and let's say it stages out as a 3. So now it came in, covered on slough and eschar, so it was unstageable. We've chemically debrided it. It is a stage 3. At discharge, it's a stage 3. We're not coding that as worse because from the fact is we didn't know what it was when it was covered with eschar, right? We didn't know what that wound was. As soon as it was cleaned up, we knew it to be a 3. But let's say it came from the previous setting and it was a 4. It's always a 4. Do you see what I'm saying with that? But let's say it developed in the nursing home and it came and it had slough and or eschar and it hadn't cleared, right? They couldn't stage it. So it left as an unstageable for them, came to you as an unstageable. You're able to chemically debride it or whatever happens. You now know it's a stage 3. You code it as a stage 3. At discharge, if it's still a stage 3, it's not considered worsened. Does that make sense to people? Do you understand that? Okay, good. If the pressure ulcer was unstageable at the sock rock, then was stageable at a routine visit or follow-up assessment, and by discharge the pressure ulcer had increased in numeric stage since the routine visit and follow-up assessment, it should be considered worsened. So now let's go through that same scenario. They came in with eschar, okay? You cleared it, it became a stage 3. During the care, so you identified a stage 3, during their care or their episode of time that they're with you, it gets worse. It now goes to a stage 4. You would then code it as worsened, okay? Because it declared itself once you cleaned it as a stage 3, but it continued to deteriorate and we ended up with a stage 4. It then would be considered worsened. Everyone get that? Yes? Okay, good. If a previously staged pressure ulcer becomes unstageable, then was debrided sufficiently to restage by discharge, compare its stage before and after it was deemed unstageable. If the pressure ulcer stage has increased in numeric staging, report it, this is worsened. So what we're saying let me translate this for you. So they get admitted into your service and they have a stage 3 pressure ulcer. Clear, stage 3. During the time on service, the wound gets covered with, let's say, eschar again, completely covered. So now it's unstageable. So then they continue on, you treat it, the eschar and the slough is removed, and now we have a stage 4. It's considered worsened, okay, because it progressed. Slightly different scenarios. One I gave you, they came in with that unstageable, right, the wound, and then it progressed. Here it came in, you knew what it was, it became unstageable, and then when the slough and the eschar was cleared from it, it now was worse and increased in stage, so in fact you would consider it worsening. And then the last one, the pressure ulcer that was unstageable at discharge due to a dressing device such as a cast that cannot be removed to assess the skin underneath, cannot be reported as a new or worsening unless no pressure ulcer exists at the site at the most recent sock rock. So for example, if I had a stage 2 pressure ulcer and you had, let's say, some sort of a removable cast and you could get in there and you could look at it, and by discharge they've now put on a cast that you can't take off and look, you can't say that it's worse. You don't know. You have to code that as unstageable due to a removable device or dressing, and it's not considered worsening because we don't know. It could still be a stage 2 underneath that. It could have healed. Who knows? Okay, so these are slightly different caveats, but they're important subtleties within the coding of these particular items. So I would take the opportunity, especially since two of these items are new for you, and make sure that you do education and training with your staff. And of course, all the various data sources, observation, medical record, physical assessment, clinical record, and you can go to Chapter 5 of the OASIS Guidance Manual to help give you some more scenarios around that. But now let's actually take the opportunity to look at some quick practice scenarios. And I think these are still in your same packet that you already had taken out. We're going to look at the new practice scenario under 1311 and 1313. So just, continue to progress in your little packet there. So let's look at the scenario we have now. So a patient develops a stage 3 pressure ulcer during their home health quality episode. The wound bed is subsequently covered with slough, hence the pressure ulcer becomes unstageable. The patient record indicates the wound debridement was performed on the stage 3 pressure ulcer 2 weeks prior to discharge. During the discharge assessment, the wound bed was observed and numerically staged as a stage 3. So let's take the opportunity to code this. So you have your scenario on the top of your coding sheets. Again, for those of you that are watching live streaming, think about how you would code this. Okay. All right, I'm looking around. I think most of the room is done. Hopefully those of you on live streaming have completed. But let's go through this scenario. So in this scenario, the first question is M1311B1. So we didn't do the whole assessment here. We carved out pieces of it, just so you know. But for this practice scenario, the number of stage 3 pressure ulcers at the start of care, the sock rock. Correct. The patient had 0. All right. So the next question says the number of stage 3 pressure ulcers at discharge. Very good. Okay. So the next question that we're asking ourselves is the number of these stage 3 pressure ulcers that were present at the most recent sock rock. Okay, good. Very good. Okay. And then the next question is that we're looking at is worsening in pressure ulcer status since sock rock stage 2. Right? Worsening in pressure ulcer status since sock rock stage 3. 1. Worsening in pressure ulcer status, and we're going to go through the scenario in just a moment. Okay, so stage 3 at discharge, it's a 1. How about stage 4? Okay, great. So then the next question is we're asking is worsening in pressure ulcer status, unstageable, non-removable dressing? Right, 0. How about worsening in pressure ulcer status, unstageable due to slough or eschar? I'm hearing 1, 2, 0. Okay, most people said 0, and that's correct. And we're going to go through again, we're going to go through the rationale shortly. And worsening in pressure ulcers since sock rock, unstageable deep tissue injury? 0. Okay, so let's go through the rationale. So on the discharge assessment, M1311B1 is coded as a 1, and 1311B2 is coded as a 0 because the stage 3 pressure ulcer developed during the home health quality episode and was therefore not present on the sock rock. I think you guys got that piece of it. M1313B is coded as 1 on the discharge assessment because the stage 3 pressure ulcer is noted on discharge. Okay? The ulcer developed during the home health quality episode. It was debrided and reassessed as a stage 3, therefore not worsened. However, it is coded as a new pressure ulcer because it wasn't present on the start of care, the sock rock. Everyone got that one? Why we would do that? Yes? Okay, all right. So that walked you through what's the rationale and why we coded what we did. All right, so we have another practice scenario, 2, and in this practice scenario, we have a patient was admitted to home care from the acute care hospital with 2 stage 2 pressure ulcers with clear fluid blisters, 1 on each heel. After a few days, the left heel stage 2 blister had ruptured and presented as a shallow ulcer with a pink wound bed. The right heel continued to evolve, having a blood-filled blister, and matured in color from a red to maroon purple color, with the area surrounding the blister being boggy, painful, and warm. The patient stated she was moving and going to stay with her daughter, who lives 2 hours away, and she was discharged to another provider. Upon discharge, the right heel had a shallow ulcer with a pink wound bed. The left heel was covered with a firm, dark eschar with slight bogginess around the eschar. So we have our scenario? Okay. So now we have to code this person on a sock rock and at discharge. So again, we took a subset of the questions. I'll give you just a moment. Okay, looks like most people are done. So let's look at this particular patient. The number of stage 2 pressure ulcers on your sock rock for this particular patient. Correct, 2. They had 2 ulcers. How about on discharge, the number of stage 2 pressure ulcers on discharge? Correct, 1. All right. The number of these stage 2 pressure ulcers present at most recent sock rock? Correct, 1. The number of stage 3 pressure ulcers on the sock rock? Correct. The number of stage 3 pressure ulcers on discharge? Good. Okay. The number of these stage 3 pressure ulcers that were present on the most recent sock rock? You guys got it. You got the skip. Again, within your automated system, this would just be a no-brainer. This would skip you automatically. All right. So now let's look at M1313A, worsening in pressure ulcer status since sock rock for stage 2. Okay, I'm hearing 1 and I'm hearing 0, and the answer is 0. Okay. And we're going to go through the rationale shortly. Worsening in pressure ulcer status since the sock rock stage 3. Good. And then worsening, since sock rock stage 4. Good. Then we have, worsening in pressure ulcer status, sock rock, unstageable, non-removable dressing. Very good. And now, how about worsening in pressure ulcers since sock rock, unstageable due to slough or eschar? Great. And then worsening in pressure ulcer status of sock rock, or since sock rock, unstageable to suspected deep tissue injury? 0, right. Okay, so let's go through quickly the rationale. 1311A, stage 2, would be coded as 1 at discharge as the right heel remains a stage 2, right? We had the 2 heel ulcers. 1 stayed as a stage 2. M1313E, unstageable due to coverage of wound bed by slough or eschar, is coded as 1 since the left heel that was a stage 2 on the sock rock is now worsened to unstageable due to eschar. A stage 1 or 2 pressure ulcer is always considered worsening if covered by slough or eschar, as it is now at least to stage 3. So that's a subtlety that some groups have struggled with So we know that if it's a stage 1 or 2, it cannot, the second it has slough or eschar, it's automatically a 3, at least a 3, because a stage 2 can't have slough or eschar, so we know it's worsened. So just, again, these are subtleties, but good things to practice with your staff. So the next scenario we have here, last, I think, of our scenarios, and this is practice scenario 3. So a patient is admitted to the home care with 2 stage 2 pressure ulcers. A mutual decision was made to transition the patient to hospice care. By the time of discharge, the 2 pressure ulcers had merged and increased to a stage 3. So let's go ahead and answer the code these for this patient. Okay, we ready? All right, so let's look at this particular patient. The number of stage 2 pressure ulcers at the sock rock? 2, good. The number of stage 2 pressure ulcers at discharge? Right. The number of stage 2 pressure ulcers present upon, were present at most recent sock rock? Very good, you guys are awesome. Number of stage 3 pressure ulcers at the sock rock? Good. The number of stage 3 pressure ulcers at discharge? Right, exactly. The number of stage 3 pressure ulcers that were present on the most recent sock rock? Right, very good, so they didn't have that. Then we have worsening pressure ulcers since sock rock, stage 2. Okay. So then we have worsening and pressure ulcers since sock rock, stage 3. Right. And then how about stage 4, sock rock? 0. Okay. How about worsening pressure ulcers due to unstageable, non-removable dressing? How about unstageable due to eschar and slough? And then how about the last one, due to suspected deep tissue injury? Okay, great. So at the time of discharge, the 2 stage 2 pressure ulcers that were present upon the sock rock merged to increase to 1 stage 3 ulcer. Therefore, M1311A1 is coded as a 0 and 1311B1 is coded as 1 at the discharge assessment. And since the 2 stage 2 pressure ulcers merged to the stage 3, the ulcer is no longer considered as present at start of care, so on discharge, M1311B is coded as a 0. Since the 2 stage 2 pressure ulcers merged and worsened to 1 stage 3 pressure ulcer during the home health quality episode, M1313B1 should be coded as 1 on the discharge assessment. So, who's brain dead? We say at work, my hair hurts. So this is tedious types of training. What I'd like to do in summary is that the quality measures for pressure ulcers that are new or worsened have multiple covariants for risk adjustment. And then you're going to hear about some of those covariant areas. The lying to sitting on the side of the bed, which is GG0170C. And then we have M1620 bowel incontinence, M1028 active diagnosis, and M1060 height and weight. It's important to understand how M1313 is used in the calculation of the quality measure and the OASIS C2 changes. So specifically, Roman numerals replaced by Arabic numbers. Each M1311 response now has 2 parts, and 2 additional unstageable categories were added to M1313. So those are the general kind of things that happened. Now, I think you have an opportunity to, what we call our action planning. You have in your folders an action plan. For those of you on live streaming, you can download the action plan, or you can just jot in your, in your pad in your office or whatever, saying, what do I need to do? So I've just listened to Ann Spinard speak for 2 hours, and we talked about wounds, and a lot of this stuff we've probably been doing for a long time, but does my staff really understand all the subtleties? Do they understand how this is going to impact my quality measures? There are some very specific changes. How am I going to go back to my agency, my organization, and train on these? So ensure that the agency has a process including tracking of all pressure ulcers and change in pressure ulcer status in the patient record. You may want to look at your process of getting information from the previous provider, especially if there's pressure ulcers involved. Are you getting the data that you need? Are you getting the staging of the worst staging for any particular ulcer? You want to review your current way you are documenting pressure ulcers in all OASIS time points. So what's your systems, what are your processes, and do all of your nurses know how to do that? You want to review and update your tracking process to include the 3 unstageable pressure ulcer categories, because those are 2 of them are new. And then I think the greatest thing is practice a variety of scenarios with staff, and you can take all the ones that we have here will be posted with the answers up after the training, so you will have all of this training material. So you can just take any one of these scenarios and just hand them out and say, this week try this scenario, that week try the other, let's get your answers in. You can use things like SurveyMonkey to do, I mean, you could do a variety of things creatively if you have staff kind of all over to make sure that they are understanding these changes. You want to make sure that you're having the discussion with your staff and be prepared to move forward. Or take cases in your own company. What kinds of complex things are you seeing? What kinds of questions are your nurses having? And maybe take some of those case scenarios, write them up, and use those as training. Very, very helpful to do that. There are a variety of resources that you can go to. The OASIS Education Coordinator, there's a link there. Home Health Quality Reporting, the QTSO help desk, so you can ask questions, and certainly you can ask questions here. So I'm actually running out of time. I do have some questions, but I think we're going to try to get to those at the end of today. And so if any other questions come in, we'll take those. We'll try to answer as many as we can today. And I think we have a question and answer first thing in the morning tomorrow. The idea is to get as many of these questions answered for you so that you have the clarification, can take them right back to your organizations and whatnot. If not, we've made a commitment to answering. Some of these questions we're like, wow, okay, a little thought-provoking. Let us think them through a little bit more. And if we can come up with those answers by tomorrow, we will. Otherwise, some might take a little bit longer opportunity for us to go back, kind of do some due diligence and make sure we have a clear and concise answer. And then those answers will be made available as quickly as possible so you can use those for training. We had a lot of information. I have like 1 minute left. If there's a burning question, if you go to a mic, that would be great. Otherwise, if you can submit them electronically or handwrite them, and we will try to recap as many of these questions this afternoon. We're fighting. Okay, yes?
Quick question.
Yeah?
You had said that if someone was a 2 and they went to a 3 within the 5 days of doing the OASIS, that you coded them as a 2, correct?
Yeah, so that's a good question, and actually that came up as one of the questions. So the idea behind this is if you go out, so you have a 5-day assessment period, and your initial, let's say you're out there within 24 hours, and your first assessment, and it's very clear.
Yeah, I understand that. My real question is, if it comes in as being unstageable with a dressing over it, and then within the 5 days we know that it's a 2, do we do it as an unstageable or do we do it as a 2?
So the guidelines that we're giving here, and I'm going to clarify with Terry, right, that we were going to do as your first assessment. So if it was unstageable due to a covered dressing, that it would be unstageable due to a non-removable dressing. I'm sorry, that's because of, I couldn't, and if you can go up to the first off, people can't hear you on the streaming video.
Saying that the variation is because of the one clinician rule. But if I'm the nurse that went on day 1 and I go back on day 5, I can change that information. But if another nurse goes,
So I will tell you for this, and because for consistency across all of the care settings, that what we are teaching and what CMS has asked the messaging to be is the first time that you do your skin assessment to be, and whatever you've coded and whatever you see, that is what you should encode on your assessment. Okay? It has nothing to do with like other rules. It's whatever the first assessment is that you've done, and that allows for consistency. That is how we've been teaching this in all of the care settings. And I think I hit that in the beginning where we have, people who are there when they're in a skilled nursing facility, the inpatient rehab or whatever, they could be looked at 3 times a day, their skin. So we really want to capture whatever it is in the first assessment.
Really quick.
Yes?
This will be a really quick comment. Earlier in one of the slides you were talking, this is the change I think we need to highlight is if a pressure ulcer is then treated with a skin graft, that it becomes a surgical wound.
Yes.
That is different guidance than what we've had in the past.
Yes.
So I just want to
Okay.
make sure everybody caught
Yep.
that because we went over it pretty quick. So.
Yes, so very good point. And that's in the slides, that if you have a flap or you have a graft of some sort, that pressure ulcer goes from being a pressure ulcer to now a surgical wound. It does not go to a surgical wound if you just debride the pressure ulcer. Okay, that's the fine line there. But it does go from a pressure ulcer to now a surgical wound, and stays a surgical wound until it's healed. I can take one quick question. If you go up to a mic, though, that's the only thing that I ask. I'm sorry to make people get up, but... And then I'm going to get the hook because I'm going to run into the next person's time.
Thelma Bowen, Healthcare Compliance Services. On the debridement question, we've always been instructed that if it's an excisional debridement, then it's a surgical wound. That
No.
doesn't apply?
No, if it's a surgical debridement, so the guidance that we're giving, if it's a surgical debridement of a pressure ulcer, it still stays as a pressure ulcer. It goes to a surgical wound if we do a flap, a graft, or something else like that, then it becomes a surgical wound. So yeah, there's these little subtle things that are going to be really important that you educate your staff on. So I really appreciate those questions and points. So if you think that we didn't highlight something clear enough and you want us to clarify or whatever with the Q&A, certainly put those in and we'll make sure that we highlight those. All right, thank you very much, and I'm going to turn it over to the next speaker.